Yes? Now suppose if the force falls on it, there is a force. Component like this. This is the angle, again, which I measured there. Whether I measure here or here, they are basically corresponding angles. Yes? They will remain the same. So this angle is my angle of the tooth. Okay? So it is the force here. It will have a vertical component and horizontal. Can you draw? This angle is how much? This will be 90 degree. Then how much will be this angle? 90 minus theta. If this is theta, 33 degree. In this case will be now it will be how much? 56 or 57. Right? How much will be this angle? This is 90, this is 33, this is almost 57, and this much is how much? Again 33, then this is 56. So angle, and this is again 33. So any angle with the horizontal is my cos theta. This I have already explained to you. Yeah? So as you increase the angulation, my cos theta will increase. Correct? And as cos theta increases, cos 90 is 0. Cos theta is 0. So that is why monoplane teeth, you must have studied when the ridges are extremely short, you give monoplane. पढ़ा हुआ ना एग्जाम से पहले समझ रहे हैं आप? And as you increase the cuspal angulation, your horizontal component will increase. Is it good or bad? Clear? समझ आए? नहीं, ये सिंपल ज्योमेट्री आप अपने घर में जाके करोगे या फिर मैं कभी इनको ग्रुप में डाल देना, मैं बना दूंगा. ठीक है? वहां पे मैं आराम से एंगल्स आपको, ये देखो ये 180 डिग्री का एंगल है ना, ट्रायंगल है. ये तो 90 डिग्री रहेगा. ये सपोज इजी सिंपलिसिटी का 30 ले लो, तो ये एंगल कितना बना? 60. ये 60 है तो ये कितना बना? 30. तो ये कितना बना? 60. और फिर से इसी लाइन को आगे ले जाओ तो कितना बनेगा? 30. ये सुनो, क्लियर है? चेंज करो. So do you want to increase the cuspal angulation of your teeth in a restoration? Yes or no? हाँ या ना? No. Because as I increase the cusp angle, it will become more and more horizontal forces will be generated. Sir, how much time I have? Other? कोई लिमिट है क्या? Sorry. थोड़ा सा मैं बड़ा. This we have already seen. Angulation should not be exceeding more than 30 to 35 degrees. Clear? Mutually protected, we have already discussed enough that nature has provided mutually protected. When the anteriors are in function, posterior out of there, when posteriors are there, anterior out of there. Okay. This force also I have already discussed in kilograms as well as Newton. 400 to 800 newtons or 40 to 80 kilograms or say 25 to 200 psi. Now at this also discuss here, as you increase the incisal guidance, will increase, the horizontal component of force will increase. Yeah? And what are the reasons for increasing the incisal guidance is aesthetics and mainly aesthetics. To achieve better aesthetics, sometimes we make this mistake. So it is better you make a shallow incisal guidance rather than for a steep incisal. Clear? Okay. TMJ and jaw is a simple case of class 3 occlusion. So that is more. Class 3 liver, you understand? Class 1 is the fulcrum is in the middle. Class 2 and 3 fulcrum on the end. You see the guy who is carrying the waste in your college as a trolley. Fulcrum at one end, fine, where it goes, load at one end, captured. Yes? When fishing hook, you have to apply a lot of force to do that. Only because of mechanical advantage, they are easily done. Right? Class 3 is a most disadvantageous thing to have. And unfortunately, the jaw is class 3, and that's why you see the most of the muscles of mastication are only inserted at the angle of the mandible. And one of the strongest muscle is the masseter in the body. You see masseter and the medial pterygoid make a kind of a sling on the medial and the buccal side, on the single side, and just carry the jaw upward. Yeah? So, as you go posteriorly, the force of mastication will increase or decrease? It will increase, and it's mainly because of the muscles of mastication, though it's a class 3 device. Okay. Now, this is one of the toughest things, whether you're doing a PFM or you're doing implant. Canine has to be replaced. It's very, very difficult. As a matter of fact, many textbooks, even today, they find that the replacement of canine ideally is done with the help of RP, not with the help of PFM. Mostly said that only canine is coming in contact. So my masticative force, the point of contact is one, so the pressure will be increased. Though as discussed, nature has provided you the longest route in the form of canine to protect it, and the canine buttress is also very strong. Despite saying that, it is one of the toughest. So when you have to replace it, what do you do? मेरे रूम में होगा स्टार्ट. So if you are going to replace any here, the fundamental fact will remain same. What will you do? Will you develop a H2H fight with the canine? Yes or no? Answers are very objective. Would you ever develop a canine guided occlusion? No. Now cantilevers. Cantilevers are the worst thing. As I said, there are two options. If I give you this chair, you sit on top of this, one, or you sit on the ground. Which one is better? Which one is more comfortable to you? Chair on the ground or chair on little higher? On the right. As you go high, the vertical offset will increase. Vertical offset will, I'll discuss horizontal and vertical in one thing, movement in physics. That is will generate the torque. Torque is defined as, suppose if I have an object here and I apply a force here. So how much is the torque? How much is the torque? Torque is defined as force into the distance. This is the distance from the center of the object to this. This is D and the force. Now this is a simplistic diagram, but force can be also at an angle. This we have discussed. Any angulated to the opposite arc will always generate this kind of condition. Clear? What do you do? This force, which is angulated, I will make two components, vertical and horizontal. Which component? Take the sine theta. Sine. Right? So, any questions so far? So, if you have to sit on a height, is it safer or you find much more stable here? The reason is torque. Same thing can happen in the horizontal component also. Suppose this is the center of my implant and you make a crown which is very bulbous. One option is that you have made a crown which is almost same diameter as your the implant. So then the forces obviously will be within the base center of the object. Second is you make a very bulbous, then you have a horizontal offset. So you can have horizontal offset. Horizontal offset is if you sit on this edge of the chair, what will happen? You will tip. Yes? And if you sit on the center, you even if a person with 200 kg will say nothing will happen. Yeah, the stability increases. So this is a very common thing that on a very small diameter implant you give a very bulbous kind of restoration to fill up the gap. Yes? Yeah? And even if the bone is not there, you tend to do it. So this leads to a lot of offsets, vertical, and vertical offset is ground to root ratio, which we always follow in FBD also will be compromised. And secondly, any horizontal force will be away from the center of my implant. So that creates more torque. Clear? Third condition is when the opposing arch is resolved, right? What do you do then? Inter-arch space is increased. Then what happens? Then you do not give any kind of fixed restoration, we go for any hybrid restoration. Correct? Cantilever, we never give cantilever in the implants. Because this diagram is what we're trying to show. As you go distally with more cantilever, the forces, bending forces will come where? On the distal implant. Because distal implant is now becoming what? It's becoming the fulcrum. This is becoming a class 1 lever with distal acting as fulcrum. So the mechanical advantage is calculated as force into force. The greater, more away you are from the fulcrum, more will be the force. And that force is what? Torque. Okay? How to compensate? Either you increase a more number of implants in the interior region, yeah, and reduce the cantilever as much as possible. In implantology, we generally do not prefer maximum, in extreme cases, 1, not 2. Okay. Ground height ratio, I've already discussed vertical offset. Yeah? Can you see it? Is it visible? This is a very common condition when the opposing arch is resolved. Here, even the arch bone where you're placing the implant is also resolved. You go in that also you tend to go little suppressed. Yeah. This is nothing but showing you along the long axis of truth. Okay. This is what I'm saying. Now, two mistakes which you common the roots are generally more flare. Fine. So it gives you, it compensates even if the crown is wide. But your forces are falling within the geometry of your base. Correct? But here, unfortunately, you can see on the left hand side, the ground is quite bulbous. The forces, now this is generating, the force should always be on the central fossa. Because if the force falls on the central fossa, it will go along the long axis of the implant. Yes. But further away it's going to create horizontal offset. And any offset will create only one thing, that is torque. That is rotational movement. Fine? And that will generate at one side tension, the other side will generate compression. Wherever the tension will come or shear stresses will come, the bone will resolve. One of the major causes of crestal bone loss is this. So that means how do we do it? One simple thing is you reduce the occlusal table for the size of your tooth nearly 30% to 40%. Usually the crown size in implantology is usually we give little less than the natural. That's one thing. But can we reduce the functional cusp? No, we cannot reduce the functional cusp because that is determined by the position of the opposing arch. Right? This is what we are trying to show you here. This is what I spoke just now. What we reduce is not the size of it, we reduce the bulk of the functional cusp. Your maximum force will come on the functional cusp, whereas the non-functional cusp will remain as it is. So that means in the lower, my lingual cusp will remain as it is. So that tongue does not come in between, and the upper maxillary cusp is the overhead cusp. Otherwise, your cheek pipe. Fine. If you reduce that, either you have a cheek pipe or you have a tongue. Right? And the functional cusp are usually flattened a little bit. So that when you make a light contact, there is no pressure on the force of the implant. Now, during heavy chewing, the forces are as good as the other. Why? Because your adjacent teeth will always get to go vertically downwards. because nearly 100 microns movement will be there, and the implant will remain static. If the adjacent teeth go downward, most of the force will fall on the implant. We don't want that. That is why we tend to keep it little low. How much lower? I'm talking in terms of anything 50 microns. Yeah? Yeah? This is what we have, how we are managing it. Forces should be along the non-axis. Offset should be minimized. I think I have to cut down because a lot of faults are there because of occlusion. This is clear. This is a wonderful diagram which all of you are well versed in multi-cast tracing. This is a multi-cast tracing. Correct? What you see here, this arrow is showing me the protrusion. This is the functional side movement and that is the balance side movement. I wish I had more time to explain you this. Correct? But such a scheme is not preferred. This is usually in the natural teeth. Because the opposite cusp will fall on the central fossa and that will slide along the slopes of the cusp. Correct? But here we don't want that. Because as I said, any inclined force on an inclined plane will generate more of a horizontal component, and here we don't want that. Yeah? This probably I'll explain you guys some of the time, not today. Okay. So what we are showing here, see the buccal side. In the buccal side, which is the functional cusp? The parietal cusp. You can see the parietal cusp has little flat. Morphology is little warped. That is just to reduce the force. Madam, your answer to this question. So the functional cusp are slightly short, flat. And usually tend to make sure you are restoring because and going axially along the long axis of it. Yeah. Now we talk about primary and the secondary forces. Primary forces when you come to the maximum MIP position, and secondary is all eccentric movements you make within the border movement, right? Whether it is protrusion or lateral explosive. Yeah. In doing all these movements, the principle is the force should be along the center of the implant, right? Central force. This we can skip. I mean, this also just talking about this. Okay, materials are very important because this is another very important matter. When you do the final restoration, what's the material of choice for any fixed tooth restoration? Ceramic. Everybody is ceramic. Now, ceramic has an inherent problem. Anything which is ceramic will be non-resilient. Non-resilient means it will not, as I said, anything which is non-resilient will have high impact. Fine? I explained to you because there is less flexibility and the area under that curve will be less resiliency. Less resiliency means immediately the force will be transmitted to what? To the underlying abutment, screw, cement, right, and ultimately to the crestal bone and implant, right? So everything tends to mechanically it is disadvantageous to have ceramic. The best material which has least the highest resiliency is acrylic. But for obviously aesthetic reasons, we will not give it. Aesthetically, obviously ceramic is the best. Right? This is what we are trying to show here. Impact is more. In fact, I've already discussed you in the beginning is a force multiplied by time. I gave you a classical example when you hold a ball, a catch ball, you always take to take an impact force. And this condition is generated in the mouth by periodontal layer. Right? Okay. In this also you can scale PFM or implant. How do you use it? You put in an articulating paper. How much is the thickness? We usually have 8 to 10 microns. Okay. So when you put the articulating paper, there will be some dots. Hypothetically say some dots have come. that is the most common mistake done by what do? You cut it. You cut it. When you are removing it, do you think of something? Whether it is the functional cusp, it is cusp or tip? No. Remember, if you cut the functional cusp, that means your vertical height of occlusion is going to get reduced. Correct? If it is a single tooth, obviously vertical cannot change. And what happens is your tooth is out of case. जब लोड ही नहीं है तो definitely patient does not come to you with any complaints. You are happy, patient is happy, but you have made the tooth out of care. Patient came for the restoration, but now restoration is useless. Yeah? So you always tend to grind the slopes of the cusp following the bull slope. I hope you're studying the bull slope. Fine? And similarly, this is only when you check the maximum intercuspal position. And after that, you have to also check the interferences in all eccentric, that is protrusive and lateral discursive. There should not be any conflict. If it is a conflict, it is called as interference. Okay? The forces on the inclined plane will always generate horizontal component and it is steady. Yeah? Am I clear? I wish I had a little more time. Okay. These are the summary, what are the things we can do. You can probably increase the support area by increasing the number of implants, longer implant, wider implant, surface modified. Thereby we are just increasing the interface between the bone and the implant. Correct? Or you can increase, change the direction of the force, or reduce the magnitude of the force. So these are the only three things we can do. Reduce the bifurcation. Yeah? Okay. So you should be always thinking of the processes first, what design you want to fabricate. That means only one thing. In which direction my force will go. Correct? Is it going along the long axis within the body of the implant, or is it based opposite? Yeah? That? Any questions? I have to rush. Right to the last part. Some of the time maybe I fine. Any questions? Okay. My question is how molar is a Gothic artist? Gothic art is just an architecture design. Fine. You use a plate extraoral or intraoral. Fine. You use an extraoral you have seen, intraoral you have seen. Even your occlusal surface of the lower is a plate for the upper functional cusp, isn't it? Similarly, for the upper occlusion surface, lower cusp can also be a Gothic arch. Yes? So that is a Gothic arch, nothing else. We use Gothic arch what you have been taught only if a patient does not have a tooth. Completely dangerous. Right? But actually recording it. All the eccentric movements your Gothic arch tracing is going on. And if it is not in unison with your portile guidance, as we discussed, or incisal guidance, you have interference. Right? Little difficult at this stage for you. For you, it should be understood very well. Any other questions? Fast, I can take 2 minutes more. Questions? Yeah? Any question, please? Thank you.
कैसा था लेक्चर? हेक्टिक? पीछे इंटर्न्स पीजीज ने तो एंजॉय किया लेक्चर काफी, इंटर्न्स ने अच्छा था। उज्जवल ठीक है, ऑल वेल? हाँ, तो मेरे से पर्सनली मिल जाएगा एक दो बार दिन में, ठीक है? या तो ठीक हो जाए या बिल्कुल खत्म हो जाएगा। अभी तुम लोग लग रहे हैं, है ना? पहले स्टार्ट करें। अरे जितेंद्र जी, जितेंद्र जी तो कितना पीछे मोबाइल बंद कर दो, पीछे गेट
गया हुआ बाहर।
गुड मॉर्निंग, सेटल हो जाओ नहीं जल्दी। क्या था फंक्शनल प्लस, क्या था मुझे भी समझ में नहीं आया। कपूर, आकांक्षा, आपका में फंक्शनल प्लस कौन सा है? इतना बढ़िया से हमने बनाया, मुझे भी फिर अब मैंडिबल पक्का, और अगर पक्कल को फंक्शनल बना देंगे तो क्या होगा? अदर वे हम सोचते हैं, अगर सीजर बाइट है, क्रॉस बाइट है तो क्या होता है ना? होता है ना? इन दैट कंडीशन द बक्कल cusp is functional and lingual cusp is in the lower it is functional, but that is very rare. So ideally it should be Wolff's law follows, BULL, है ना? याद तो है बिल्कुल थोड़ा थोड़ा। अच्छा, so we start with another lecture of the day, that is the graph versus graphless procedure, and mostly in my PPT there are the cases we had in last 1 year. Okay, so if I ask you, because you all are placing an implant and most of you are did the secondary surgery also, so what type of challenges you are seeing in your cases during the implant placement? Any challenges or all are doing the conventional cases? क्या challenges हैं? Only the gingiva is it or the bone morphology like that? So actually there is a concavity. Okay, so there is a concavity that is because of the resorption of the bone pattern. Okay, so you have to understand where is the concavity. Most of the time it is on the buccal side. Okay, not on the palatal side or the lingual side. So according to that you can plan your implant site. Okay, either you put your implant on the palatally or in the center, or sometimes you have to put your implant on the buccal side also. It all depends on the bone morphology. Okay, so we have multiple types of graft and graftless procedure nowadays. In a modern era of the implantology, these type of procedure we can do it very commonly. For example, sinus lift, everybody knows. Sinus lift, it is a two type. One is indirect sinus lift, other one is a direct sinus lift. We can go for the bone grafting as well as we also not going for the bone grafting and put an implant simultaneously during the indirect sinus lift or the direct sinus lift. I think this topic is already covered. Yesterday Dr. Rahul talked about the indirect sinus lift. Second is the vertical and the horizontal ring augmentation. So everybody knows about when there is one classification in with the class 1, class 2, class 3, class 4, and that is the vertical bone defect. In the class 1, there is a papilla is completely in between the two teeth. That means there is no vertical bone loss. In class 2, there is a minimal bone loss. Class 3 is a more bone loss, and class 4 is the more than 50% of the papilla is going up. That is in the case of recession. Fine. So we can talk about the vertical and the horizontal ring augmentation. What are the different graft procedure can we use, and what are the different graftless procedure we can use if there is the vertical and the horizontal bone deficiency. Third is the sandwich technique. Like the sandwich, there are multiple type of sandwich nowadays. अगर आप सबवे में जाओगे तो कोई बोलता है मुझे 1000 आइलैंड सॉस डाल दो, कोई बोलता है लेट्यूस डाल दो, कोई कुछ डाल दो. So in the same way, we have a multiple type of sandwich technique in a bone grafting procedure, or if you increase the vertical and the horizontal height. Okay, the sandwich means you are putting something in between the two structures. On the same way, we have to cut the bone if you increase the vertical height and put something inside it. Either it is the autogenous graft, either it is the xenograft, or allograft, or the alloplastic material, right? And if you are not putting a graft, if you don't want to put a graft, then we have another procedure that is called as alveolar distraction. So that means we have put one distractor type of component and then increase the vertical height simultaneously. Then we have a ramal and the symphysis bone graft. It is a very common nowadays. If you have deficiency of the bone in the anterior and the posterior region, locally you can remove the chin graft or the chin bone or the ramal bone or the body bone and you can fill that defect. Okay? Then autogenous tooth graft. Autogenous tooth graft is very common in Korea. Only that autogenous graft museum is placed in Korea and it is very simple method. You can go and do it on the chair side also. So I will show one video how we make it and what are the results. Then other only graft you can use the rib graft, you can use the fibula graft, you can use a erectus graft. Then another minimal invasive technique for grafting harvesting, the refined bone skin graft. It is a round wheel-like structure. You can go inside the symphysis and remove a chunk. So it is a very minimal invasive procedure. Guided bone regeneration, everybody knows about it. We put a graft, over the graft we put a membrane. Without membrane, we never say it is a GBM procedure. We have to put a membrane over the graft. And why we have to put a membrane? Anybody? Very good. अगर membrane place नहीं करेंगे तो क्या होगा? So membrane will act like a barrier. If you are not putting a membrane, the bone graft is attached with the soft tissue as well as from the bone. So second time onwards, whenever you reflect a flap, the whole graft is coming out with the soft tissue or the flap. Okay, so we make a barrier in between the soft tissue and the bone graft material. Last one is the more aggressive surgical procedure. If you want to increase the vertical height, we go for the Leafold 1 osteotomy. So everybody in your BDS time, you read about the Leafold 1 fracture. So Leafold 1 fracture, we completely fracture the maxilla and increase the height or decrease the height. The non-graftic solution, angulated implants. This is a new concept, tilted concept or the angulated concept, in which all-on-4 concept. So Dr. Sumit will taking another lecture on the all-on-4 concept and all-on-6 concept. Zygoma implants, yesterday we did. The zygoma, pterygoid implants. Other one is cortical implant and the basal implant. Now these terms are combined together nowadays and we say it is a cortico-basal implant. Cortico-basal implant means you can take an anchorage from the basal bone or the cortical bone. That means if you have a mandible, there is a basal bone at the inferior border and the cortical bone at the buccal side and the lingual side. So you can take an anchorage from the basal as well as cortical bone. Otherwise the implant will not survive. Okay, if you have put a cortical implant in a medullary cavity, like the conventional implant, it always fails. So you have to take an anchorage from the cortical and the basal bone. Why it is so? Because basal bone never resolved. Okay, only the alveolar bone is resolved, basal bone is never resolved. So if you take an anchorage from the basal bone, your implant will never fail. In case of conventional also, okay, if you have a less amount of bone and you take an anchorage from the either from the vital structure like the nasal probe or the sinus probe or the any of the cortical bone, it never fails. Right? Other thing is the bone expander. Anybody heard about the bone expander? No? Bone expanders means we have to expand the bone. So bone expander is basically used to increase the horizontal width of the bone. Okay, we have to cut the bone and expand it. So initially there are only the hand instrument for the expansion of the bone, but nowadays it is more motorized, or we also use tensor burr for the expansion of the bone. Right? Then the tensor burrs. Everybody saw this movie? अंग्रेजों के जमाने की जेलर है. So you are all like jailers. असमानी. कैसे? सबने implant डाल दिए. Everybody is confident now. कि I am able to place implant. I am placing implant. Everybody is like a jailer. कि हम implant डाल सकते हैं. But once your implant is failed, Sanjeev Kumar, helpless. Because and we have a very half-hearted knowledge. We are only place an implant in a conventional bone or the delayed bone. We are not doing a more complicated case because the complication is more in cases of a challenging cases where the bone is less, width is less, vertical height is less. Okay, so keep learning and keep placing implant on a regular basis, right? So never be overconfident doing the implant place. हमारे भी implant fail हो जाते हैं. जिस दिन हम सोचते हैं बड़ा easy है, वही fail होता है. ठीक है? So before placing implant, you have to know about the anatomy. Okay? In anatomy, in the mandible, we have there are some vital structure like one nerve. That is inferior alveolar nerve that starts from the mandibular foramen going down and down. First is run in the posterior area on the second and the third molar area. It is runs lingually, and in first molar area it comes in the middle of the mandible, and then it comes buccally, and then कहाँ से निकलती है फिर? Mental foramen. Mental foramen area it will divide into one is mental nerve, another one is the incisive nerve, and incisive nerve is always in the center of the mandible. So always remember whenever you put an implant. In cases of the mandible, posteriorly till the first molar area, your implant should be more buccal side. Inclination is towards the buccal, and your drill is slightly straight or on the lingual side. So that means apex of the drill is towards slightly on the buccal of the center, and the coronal section of the drill toward the lingual side. Correct? And in anterior region, it is more toward the straighter one or follow the curvature of the mandible. In cases of on the lingual side, the only one structure is lingual nerve. So lingual nerve, most of the cases if we see the literature, it is A is the vertical from the crest, vertical height from the crest. It is 8.3 mm to 4.05 mm, and B is the distance from the horizontal distance. So that is around 4 mm. So that means never perforate the lingual side of the soft tissue. Correct? Most of the time, whenever you put implant, you reflect both the flaps, buccal side as well as on the lingual side. So lingual side don't go deep more than 4 mm. Okay. Otherwise, the lingual nerve is exposed, and after the implant placement, patient give a history either of the paresthesia or sometimes dysesthesia. Okay. During this presentation, I prepared this presentation. I come across one of the old article. That is the past, present, and the future of the oral maxillofacial surgery, and that is given by the Daniel Laskin. Okay, Laskin की book सबने देखी होगी. BDS time में there are 2 volumes of the Laskin, and divide the oral surgery specifically into 3 parts: the area of expertise, area of competence, and area of fame. Right? So in all the dentistry, these 3 categories, I think it is true for every faculty, every stream. Because, for example, if I take a prostho, what is your area of expertise? Initially, the prosthodontist is known only for the tension, RPD. That is your area of expertise. But the area of competency is if you are trying to make obturators, if you are doing a more complicated, that is the area of your expertise. Area of fame is if you go for the super specialization. For example, nowadays implant placement we are doing with the help of navigation system. If you are doing more practice in the navigation system, you will get a more fame. If you are doing a more complex cases, you will get a more fame. If you are rehabilitating more number of cases, you are more fame. Okay, so try to go the area of the familiarity or the fame. Now we come to the introduction part. As we all know, once the tooth is extracted from the alveolar socket, what happens? The bone will dissolve. In the maxilla, it is in the centipedal mode, and in the mandible, it is in the centrifugal mode. and it is very challenging for each and every dental professional to have rehabilitate the edentulous patient. Correct? Because there is no tooth, no occlusal stop, you have to make a new occlusal stop during your rehabilitation. The reconstruction of the atrophic jaw caused by the edentulism has necessity, sometimes complex grafting procedure. It depends on you, how you treat the patient, how you talk to the patient, and patient is willing for that or not. It carries significant morbidity and cost associated with it. So whenever you go for the grafting, what is the main disadvantage? One is morbidity, because you need a donor site. Correct? For example, if I am taking a iliac crest graft, we have to go for the surgery under GA, and we have to remove the bone, hip bone. So that is very morbid for the patient sometimes. And second is the cost effective. Second, the less invasive graft approach to the atrophic jaw rehabilitation are preferred nowadays, because nobody wants surgery. Nobody wants a second surgery for the graft. So that's why the graft-based approach nowadays are more common as compared to the graft. What is graft? Okay, very good. So whenever there is a lost tissue in the body, for example in a jaw, either it is a soft tissue or a hard tissue, you can take some bone substitute or the soft tissue substitute and put it there in a lost area. So that is graft. The only difference between the graft and a flap, sometimes you heard about the flap also. So the only difference is the graft doesn't have its own blood supply. Okay? But the flap is at its own blood supply. That is the difference. So मिशन इम्पॉसिबल, तो मिशन इम्पॉसिबल था उसमें कि नहीं था, या पॉसिबल था? आजकल तो कहते हैं एवरीथिंग इज पॉसिबल, नथिंग इज इम्पॉसिबल, कहते हैं कहानी पॉसिबल है कि नहीं है, या कुछ केसेस में हम कहते हैं पॉसिबल है। तो जब से हमारे corticobasal and the zygomatic implants come into the picture, we can say everything is possible nowadays. Correct? Other thing is the PSI, the patient specific implants. Okay, if you doesn't have any bone in the patient jaw, okay, very atrophic architecture of the mandible and put some abutment that particular structure, that is called as PSI. So that is patient specific implant. The only thing is we need a surgery. We open it up and fix it like a plate. जैसे trauma में हम plate fix करते हैं, on the same way we make a structure, full structure of the jaw and put it in the maxilla of the zygomatic bone. So nowadays everything is possible. So this is the normal physiological process. There is a tooth. After the tooth extraction, there is a resorption of the both on the buccal and the lingual side. But in cases of maxilla, what happened? Once the bone is resolved, there is another thing is pneumatization of the sinus. So that's why we have lost more of the bone on the posterior area, because maxilla is present on the premolar to the molar area. So less bone, vertical bone present after the extraction because of the resorption in two phases. One is the bone, and second is because of the pneumatization of the sinus. The factor complicated the conventional implant placement, especially in cases of maxilla. The centripetal pattern of the alveolar resorption, pneumatization of the maxillary sinus, presence of the nasal fossa and the nasopalatine duct in an anterior area, and poor quality of bone. Agree? Correct? As compared to the mandible, maxillary bone is more porous, less dense, so poor quality of bone. Second is the more vital structure present anterior as well as posterior in case of maxilla. So in the anterior, nasal fossa, and in a center is the nasopalatine duct. Correct? And pneumatization of the maxillary sinus is as posteriorly. If you see the pattern of the bone resorption, it is not consistent either in the mandible or the maxilla. In the anterior mandible, if you see, most of the time with the edentulism for the longer time, loss of height and width. Agree? अगर maxilla anterior होता है, तो उसमें ज्यादातर आप देखोगे कि vertical height भी नहीं होती और horizontal height भी नहीं होती. That's why this area is the most difficult area to rehabilitate. Okay? Always remember, anterior mandibular area is the most difficult area to rehabilitate because the bone resorption in both the direction, vertical as well as horizontal. Second is the posterior mandible, loss of height mainly. But if you see the edentulous, अगर आपने implant case किया होगा in a delayed cases also, there is a good width, but height is less. Correct? In a posterior mandible. In posterior anterior mandible, both height and width is less, but in posterior mandible, only the height is less. Most of the time, is the issue of height. Then we come to the anterior maxilla, loss of width 2 times of the height. Agree? देखा है कभी ऐसे? Anterior maxilla? Because there is a centimeter resorption. If you see the patient, it looks like a retrographic maxilla. Because buccal bone is also resolved and vertical bone is also resolved. In the posterior maxilla, because of the pneumatization, only the height as well as slight width is also reduced in cases of normal architecture of the gingiva. ठीक है, जिसको बोलते हैं tight contacts. ठीक है, तो there is no bone resorption case of class 1. अगर हम उसको horizontal loss से compare करते हैं, तो there is no reduction in the buccal and the palatal or buccal and the bone. ठीक है, तो it is a normal डाल सकते हो. Either it is the immediate percent of the loss. अगर हमें याद हो तो एक प्राइमर होता है पैपिला का. ठीक है, अगर वो पैपिला रिसेस करके जितना पैपिलरी लेंथ होता है उसमें लेस देन 50% है, that is come under the class 2. Okay, class 3 is the severe loss of the papilla. बहुत severe recession हो गया, पूरा जो gingiva है that is rolled out, margins are rolled out and there is a black triangle. So that is called as class 3. And class 4 is अगर हमारे दांत ही नहीं तो क्या होगा? Edentulous हो जाएगा, है ना? So there is loss of complete papilla. That is come under class 4. So which one is the more difficult case? Class 4 or class 1? Class 4. Okay. Class 4 is the most difficult area because इसमें aesthetic concern भी सबसे ज़्यादा होंगे. And you have to rehabilitate either with the overdenture or with the other कौन सा होगा आपका overdenture के अलावा PFM crowns with a long bar. ठीक है, वो भी हम ले सकते हैं. तो लेकिन gingiva architecture is not like your natural tooth because it is completely edentulous. In the horizontal defect, first is the normal. Class B is the limited loss of the buccal tissue. Buccal tissue means buccal bone. और bone loss होगा तो tissue भी loss होगा उसके साथ. C is severe loss of the buccal tissue. That means the bone loss is above the CEJ. And class 4 is only the apical 1/3 of the tooth is inside the bone. That is class D. So this is the vertical bone loss. If you see in the first diagram, there is a slight loss of the papilla. In a class 2, there is a triangle that is not complete. In class 3, there is a black triangle. In class 4, edentulous. Based on the horizontal, class 1, no buccal and the palatal bone loss. Class 2, there is a slight bone loss in the buccal side and the palatal side. Class 3, the bone loss below the CEG. And in class 4, only the apical 1/3 of the tooth inside the bone. Okay, so according to these defects, we can decide in which cases we are going for the GBR, in which cases we are going for the chin or the lamellar graft, in which cases we are going for the more block graft. The goal is hard tissue augmentation. Second is to provide the foundation for the ideal implant minimum column. If it is more, it is good for the survival. If it is less, that means there are more margins. So we have to need minimum of 1 mm of the fur around the implant. Okay, so try to put implant whenever you put implant. Try to in the place where your bone width is good and minimum 1 mm of the implant bone column should be around the implant. Right. Second is to support soft tissue for the optimal aesthetic. For example, there is a bone loss anteriorly. Now we know there is a bone loss on the buccal side more in the neck. So whenever there is a bone loss, there is a concavity. So this concavity also support the soft tissue. Your soft tissue also looking like a concave. So how we make it more aesthetic? We have to fill this concavity either with a bone graft or with some material which support the soft tissue. Correct? So once we fill this concavity with a bone graft, either with the particulate bone graft or with the vertical bone graft or with the medullary bone graft, the soft tissue again having a fullness like the original one. Second is augmentation of the bony defect is done either in a conjunction with the implant placement or stage procedure. That means you have to decide if the bone width is good enough, okay, and there is a concavity, and only one or two threads are exposed, then you have to place implant simultaneously. That is according to the CBCT examination. Okay, if your implant is completely exposed on the buccal side, try to avoid the implant placement. Okay, for example, if you have a bone width of 2 mm, can you put an implant in that case? Or 3 mm? It is difficult to put. Fine. So minimum bone width should be 3.5 to 4 mm. You have to put implant, and if one or two thread is exposed, then you go for the either GBR procedure or some other procedure. Correct? Stage procedure in situation there is a large bone defect where the primary stability is questionable. Understood? यहाँ तक कोई problem है? So whenever there is a large bone defect, bone width is not good, bone height is not good, abandon that procedure, do grafting first, and then you go for the implant placement in second stage. Or you search for the other option like all-in-4 option, zygomatic option, or the vertigo-basal implant. Okay, but if you want to do the grafting, always check for the defect size and then you do. For example, most of the time the autogenous graft, okay, but if you need of around 2-3 centimeter the size of the defect, you have to fill with the autogenous graft, then we have a very limited option. For example, if it's lip graft, okay. Otherwise, the genome graft and the autogenous graft means it is very cost factor is the thing. If you are putting a genome graft or the allograft in the okay. So most of the time if we need a bone more than 8 bone graft. Okay. So iliac bone is a very good bone. We can remove the medullary cavity and put it in the defect side. Bone graft, autogenous, and the various type of graft. Autogenous is a gold standard because it has all three properties. What are the all three properties? Osteogenic, osteoconduction, and induction. That means osteogenic means it can form the bone, induce some growth factor which help out in a formation of bone. And osteoconduction means it acts like a scaffold and native bone से वो क्या करेगा? Growth factor लेगा and promote करेगा for the bone formation. Right? In the allograft means what is allograft? Allograft याद रखो, it is a cadaveric bone. Okay, it is a cadaveric bone from every have to load after a 4 months. Okay, in cases of autogenous. Okay, if you are putting a allograft, then 6 to 9 months is the time period. And if it is a xenograft, then 9 to 12 because it resolves very late. Okay, autogenous it is a self-patient bone, so it is resolved faster and making a new bone faster. So you can load after the 4 months. That's why the direct sinus lift or indirect sinus lift, if you are using a autogenous graft, you can load the implant after 4 months. But यहाँ पे हम क्या करते हैं? यहाँ पे भी हम 4 months में load करते हैं, and that is one of the reasons for failure. ठीक है? If you load after the 6 months, then you see the result. It is entirely different. Okay. So always remember 4, 6 to 9, 9 to 12. ठीक है? Okay. So indication of various bone augmentation procedure according to the defect size. So first is marginal. Okay, very minimal. Only the threads are exposed. Then you go for the GBR. GBR सबको पता है ना आपको? ठीक है? GBR कर सकते हैं. So GBR में it is not necessary you always put a membrane from outside like collagen membrane or some other membrane. You can take a patient blood, make a PRS membrane and put it on a bone graft. Okay. Then is small, that is 3 to 4 mm. Or you can use a titanium mesh. Okay, time is a titanium mesh. कभी टाइम उसको सोचो कि कितना टाइम देख रहे हैं उसमें. It is a titanium mesh. Though titanium mesh is always advantageous over the GBR because it will provide a support to the graft material. Okay, and it will provide very good result. Third is intermediate, 4 to 7 mm of defect, flat or uneven. Then again the titanium mesh we can use, and it is stage procedure. Whenever you use a titanium mesh, always it is a stage procedure because we have to remove a titanium mesh. अगर टाइटेनियम मेश लगा रहेगा तो इम्प्लांट कैसे डालेंगे उसमें, है ना? तो पहले बोन ग्राफ्ट प्रोसीजर को बिल्ड करके वी हैव टू मेक अ बिल्ड विथ एज वर्टिकल बोथ, एंड देन इन अ सेकंड स्टेज वी रिमूव अ टाइटेनियम मेश एंड फिट द इम्प्लांट. That is the last defect. It is more than 10 centimeter or larger than 10 centimeter. Then we go for the distraction osteogenesis. Dog is not dog. It is distraction osteogenesis. सबको सारे डॉग एक जैसे नहीं होते, ये अलग तरह का, ठीक है? इट इज डिस्ट्रैक्शन ऑस्टियोजेनेसिस. तो डिस्ट्रैक्शन ऑस्टियोजेनेसिस मींस डिस्ट्रैक्शन एंड ऑस्टियोजेनेसिस मींस किसी चीज को द टू पार्ट्स वी आर डिस्ट्रैक्ट. जैसे मैं भी आप लोगों को डिस्ट्रैक्ट कर रहा हूं, उधर से आधे लोग खींच रहे हैं, इधर से मैं खींच रहा हूं. सैंडविच टेक्निक. फर्स्ट इज द बीएमपी, बोन मॉर्फोजेनिक प्रोटीन डाला, उसके ऊपर मेम्ब्रेन लगा दिया एंड टाइटेनियम में से सील कर दिया उसको. दैट इज द मोल्डेड टाइप ऑफ ऑनलेट. सेकंड इज सैंडविच. डिस्ट्रैक्शन से भी हम सैंडविच कर सकते हैं. देन रीवैस्कुलाइज्ड बोन, जिसको मैंने बोला था सम टाइप ऑफ ग्राफ्ट हैविंग इट्स ओन ब्लड सप्लाई, दैट इज कॉल्ड एज फ्लैप. So we take a flap from the fibula or the radial forearm and put it over the defected side. Inlay means some